Hello toppers, today we will be seeing MCQ notes related to few of the connective tissue disorders. So let's see what are all the connective tissue disorders we are going to discuss today on MCQ point of view. First one is wegener granulomatosis, next polyarteritis nodosa, temporal arteritis or giant cell arteritis, then Kawasaki disease. Let's start with wegener granulomatosis. So, most common involvement of wegener granulomatosis can be seen in the upper respiratory and ENT. What are all the manifestations? The manifestations are nasal septal perforation, otitis media, strawberry gum and gum ulcers, mucosal ulceration of nasopharynx and subglottic stenosis. Then in case of lower respiratory, that is lung involvement, it is second most common, and in case of wegener granulomatosis, it will be like cavitatory nodular lesions. And in case of renal, there will be RPGN, that is rapidly progressive glomerulonephritis, and it is also called as crescentic glomerulonephritis. And there will be hematuria, proteinuria and RBC cast in urine. So the most important MCQ from this point is like it will be involving the upper respiratory tract more common, okay. Then, in case of skin manifestation, there will be palpable purpura, digital ischemias and gangrene. And in case of joints, there will be arthralgia and migratory polyarteritis, and it is not destructive. But in case of rheumatoid arthritis, we can see destructive, so there will be deformity. But in case of SLE, wegener granulomatosis, everywhere, we won't be finding any destructive arthritis. Laboratory features. So first thing, ESR will be markedly elevated and there will be anemia. There will be leukocytosis and elevated platelet count. And in case of urine, already we had seen there will be hematuria, proteinuria and RBC cast. So then ANCA positive, this we had seen in our previous video regarding the type of vasculitis, and there will be rheumatoid factor positive and there may be chances of anti-GBM antibodies positivity also in case of agonist. Then the complement levels of normal are increased. Here the MCQ question will be in the pattern of they will be presenting a case and we have to arrive at the diagnosis. So these are all the features they will be presenting to us in the question. Next. Polyarteritis nodosa. Here the disease is confined to artery rather than the venous circulation, and then it does not cause granulomatous inflammation, as we know already it is a non-granulomatous disease. Then ANCA is negative, this also we had seen already, and it has a strong association with hepatitis B. This is one of the most important MCQ. So let's see few exceptional points related to polyarteritis nodosa. And in case of involvement, it will involve all the parts of the body, all the organs of the body except lung. And the renal involvement is more common, but it will present as arteritis and it won't be presenting as glomerulonephritis. These two things are more and more important. Then there will be hematuria and proteinuria, that is common to these things. So if we are having MCQs, they will be giving these two things as an excluded finding. Then comes giant cell arteritis or temporal arteritis. So it will be involving the extracranial branches of external carotid artery or temporal artery, and it will cause granulomatous inflammation. Yes, we had already seen regarding that in the previous video. Who are all the risky patients to develop this giant cell arteritis? They are elderly patient more than 55 years, that is age is more important and it is more common in women and white people. And in case of laboratory findings, we can see anemia and raised ESR, that is more than 50 mm per hour in 90% of cases. And if there is vasculitis of temporal artery, let's see the features. There will be headache surely, and it is the most common symptom and it will be localized mainly over the temporal region. Then comes jaw claudication, and it is the most specific symptom. So be clear, the most common symptom is headache and the most specific symptom is jaw claudication. There will be pain in the masseter muscle and prolonged chewing. Then we can see polymyalgia rheumatica in 40% of cases. Then if there is vasculitis of ophthalmic artery, how it will present? It will present as visual loss or blindness, and this is the most feared complication because it is irreversible. And there will be diplopia also. So this most feared complication is an important MCQ from this point. So now let's see regarding the Kawasaki disease. Already I had told regarding the other name of Kawasaki disease, that is mucocutaneous lymph node syndrome, and it is one of the medium vessel vasculitis and it is non-granulomatous, everything you people know. And it is an immune mediated injury to vessel endothelium. There will be infiltration of mononuclear cells and it mainly affects children. Okay. So the laboratory findings: 2D echocardiography or angiography should be performed to exclude the serious coronary complications, and there will be thrombocytosis and there will be ESR elevated. In most of the condition we can see elevated ESR because it is basically an inflammation. And there will be CRP elevated as it is an acute phase reactant. If there is any inflammation in the body, surely CRP will get elevated. Then leukocytosis will be there. So let's see the manifestations of Kawasaki disease. This is most important. So what are all the changes in extremities? We can see erythema in palms and soles, edema of hands and feet, and periangual peeling of fingers. Then comes changes in lip and oral cavity. There will be erythema, lip cracking, strawberry tongue, injection of oral and pharyngeal mucosa. Already we had seen regarding strawberry gum. So try to remember which condition we can see strawberry gum, and in case of rash there will be polymorphous exanthema. Then in case of lymph node involvement, usually it will be unilateral, non-suppurative, and it will be more than 1.5 centimeter. Then in case of vasculitis, if there is involvement of coronary arteries, it is considered to be the most dreaded complication, and coronary artery aneurysm we can see in 25% of untreated patients. So here we can find a strong association between Staphylococcus aureus that releases TSS toxin 1 and Kawasaki disease. So already we had seen hepatitis B is strongly associated with PAN. As such, this condition is also more important. Okay, I will give you the question pattern in the comment so that you can understand how this question will be asked in the examinations. And thank you so much, study well toppers.